Again, welcome everyone. This is
Recording
Cassie.
in progress.
This is Cassie Sauer at the Washington State Hospital Association, and we're giving everyone recording privileges, and then we'll start as soon as that's done in a minute or two.
Good on my end.
Ryan, are you ready or still going through them?
Sorry, just one more moment.
Okay, thanks, Ryan.
Okay, should be good to go.
Great. Thank you. Good morning. Thank you so much for joining us. You could take that slide down, please. Thank you. Thank you so much for joining us. This is our, we hoped, concluded and now recurred Hospital Association media briefing on COVID. As you all recall, we stopped doing these media briefings a couple of months ago because things were better. And we had hopes that we could be done talking about COVID. And I'm sorry to say those hopes have been totally dashed. We have got a excellent group of panelists today who all of us have really sobering news to share and want to be sure that this is getting out to the public. So we've got Mike Glenn, who's the CEO of Jefferson Healthcare in Port Townsend, who can speak about what's happening in rural hospitals around the state. We have Dr. Mark Johnson, who's the infectious disease specialist at Confluence Health in Wenatchee, which is a community that's been hit particularly hard by COVID. Dr. Tanya Sorensen, Executive Medical Director for Women's Health at Swedish Health Services. New and really frightening news about what's happening with pregnant women and COVID. And finally, Dr. Dave Carlson, who's the Chief Physician Officer at MultiCare Health System, which has serves the greater Pierce County region and also Spokane. So thank you all very much for being here. So I'll start, as I always do, with some opening comments, and they're terrible today. So we told you at our last media briefing that we had more COVID cases than we'd ever had, and that we were hoping that they were beginning to level off. Today, we have even more than that. There are, as of this morning, 1,570 COVID positive hospitalized patients. That is multiple large hospitals. If you just took a hospital and filled it with COVID, that would be multiple of our largest hospitals in the state full completely of COVID patients. This is enormous stress on the healthcare system to have this many patients with a single diagnosis. This doesn't happen. Like you don't have this many people out of not out of nowhere, because we've known about this virus coming, but just with a single diagnosis coming in and really filling up your hospital. So it's very, very alarming. There are 188 of those patients are on ventilators, and we're starting to see the deaths go up. It looks like from the reporting this morning, there's 25 or 30 deaths in the last reporting period. As we've experienced throughout COVID, you see cases go up, then you see and then a couple of weeks later, you see hospitalizations go up, and then a couple of weeks later, you see deaths go up. I don't know if you all saw this as well, that Oregon has brought in refrigerated trucks to handle the number of deaths. I think their surge is a little ahead of ours. And so that's just super alarming for us. So that, we have this sense at the Hospital Association that the public generally thinks things are more back to normal, that people are going about like having parties, going to fairs, Labor Day events, just real worry, that the public perception of where we are does not match what's happening in hospitals, where people are coming in very ill and having extended stays and even dying. So we really want the public to understand that this remains incredibly serious. Vaccinations are still the key. 90 to 95% of the patients that we're seeing in hospitals who get very ill are unvaccinated. And so I'd love to hear from each of our panelists. I know you all have looked at your own patient loads to see who's vaccinated and not. So we'll have a chance for folks to talk about that. But people, it's not too late to get a vaccine. Go today, get a vaccine, get the series started. And the last thing I want to note is that our hospitals are also, in addition to a huge number of COVID patients, we also have a very large number of patients who have completed their medical care, who we're having challenges in getting them discharged out of the hospital. They don't have either don't have a safe place to go to at home, or the nursing home that they might go to is challenged with staff, or we're having trouble hearing back from their insurer to authorize their movement, or their family may not be responsive, a whole variety of reasons. They may have, they don't have medical needs, they may have dementia or intellectual disability that may be challenging to find them a place, for example. So we are continuing to work with the state. The state's made some very positive moves in this area in the last couple of weeks. We are urging the state to really expand and accelerate this work. Are pleased with what's happened so far, but it's something that needs continued, very focused attention. So with that, I'd like to hand it over to our panelists. And Dr. Johnson, I think I'd like to start with you, because I know that Wenatchee is a particular hotspot for COVID, that you all have been really challenged to provide care for all the patients that are coming to your doors.
Thanks, Cassie. First, I would say that there was a brief moment on the 16th of June where we had 0 COVID patients hospitalized in isolation. It lasted for 2 hours. And since that time, things have obviously changed quite a bit, both in our hospital and across the state. I'll start first by saying that Confluence Health is a 170-bed community hospital serving the 4-county region of Chelan, Douglas, Grant, the western half of Grant County, and then Okanagan County. And we have a catchment area of about 250,000 individuals. We're a large community hospital with the full complement of specialty services, with just the one exception of plastic surgery and then pediatric subspecialties. So we have seen a profound shift in our COVID cases. We knew this was coming. First, I'll just start by saying what we're seeing in our outpatient, in our drive-through vaccine and testing site. So over the last 4 weeks, we have seen a 3-fold increase in vaccinations at our drive-through vaccine site. And that's good news, but I think that's driven by what people are hearing with increased case counts, morbidity, and mortality with the Delta variant. So we've also seen a profound increase in total number of tests. So previously, about 4 weeks ago, we were doing about 140 tests per day. And now we're up to 400 tests per day just at our Wenatchee site. So that doesn't include our outlying sites. So that's a significant change in what we're seeing, but we're also seeing a big jump in test positivity, going from around 4 to 5% to going to around 20%. And so that obviously is concerning and reflects what we know about the Delta variant. So over the last 7 days, we have done 3,106 tests with a 19% positivity. 84% of these individuals who are testing positive of all comers are unvaccinated. So even with the Delta variant, the vast majority of our positive cases are unvaccinated. But now I want to talk about the inpatient environment. So to give you a snapshot in time, we had anywhere between 5 to 8 COVID patients admitted to our hospital in late June, heading into early July. But then over the last 3 weeks, we've had 30 or more severely ill COVID patients admitted to our hospital, and currently that number is closer to 40. And the vast majority of patients admitted with severe COVID are unvaccinated. So as of the 23rd of last week, we had 37 patients with severe COVID admitted to hospital. 14 were considered in critical condition. None of our critically ill patients were vaccinated. So in other words, we're seeing very sick, unvaccinated persons. But what's also interesting is the age range. So that age range was anywhere at that point between 23 and 86 of all our severe COVIDs admitted to hospital. But amongst those 14 critically ill patients, more than 40% of them were age 40 or younger. And in the last week, we have had 2 third trimester unvaccinated pregnant persons admitted to hospital with severe COVID who had to undergo emergency C-section. So this is very telling data. This reminds us again that COVID-19 is becoming a pandemic of the unvaccinated. And we know that people who are vaccinated are still going to get COVID. This Delta variant is just so infectious. So we know we're going to see breakthrough cases, and we are. I just told you that 16% of all our positive results through our drive-through testing site last week were vaccinated. But most of these patients are ending up in the hospital. And we just know this. This is largely a vaccine preventable disease. So although we've made a lot of progress, we're just seeing a profound number of unvaccinated persons admitted. Today in our hospital, we do have one critically ill, fully vaccinated COVID patient. They're in their late 50s and they're very immune compromised. So we're going to keep seeing that particular subset of patients, and we are. But the vast majority, again, of these hospitalized severely ill patients are unvaccinated. And the vast majority of them are expressing supreme and profound remorse when they find out how terrible this disease is. Our staff are incredibly exhausted. And we had discussed a few days ago in the local newspaper that we are just going to keep doing our best, taking the best possible medical care of all these sick patients, but we're exhausted. We are really low on staff. We have critical staffing shortages. We intermittently are not able to accept transfers. Bed space is at a premium. We've, of course, curtailed elective cases. The health care system is really struggling as a result of this. So, right now, 24% of our inpatients have COVID. This is untenable. So it's spread throughout the county. So as of today, 15 are from Chelan, 9 are from Douglas, 8 from Grant, and 5 from Okanagan. So it's not just one county, but it keeps flaring up. And since the Town Toyota Center mass vaccination site closed on the 1st of July, we are doing the lion's share of the vaccination in our town, along with some of the other community partners like Columbia Valley Community Health, to name a few. So our health systems are really working together to try to get people vaccinated, but we're struggling. And so I'll just conclude by saying, this pandemic is impacting us in other ways. I know that my health system is not the only one that is dealing with a critical shortage of blood culture vials. So as of today, we have a profoundly reduced ability to do in-house blood cultures anymore because we just don't have the bottles, because supply chain issues are impacting not just COVID care, but all other aspects of care. That's where we are. And that is shocking to me, and I hope it is to everybody else who's listening. I would also say that we know these vaccines are incredibly effective at preventing severe COVID, and they're largely very safe vaccines. But Delta has changed the game. We know that people who are vaccinated are going to get COVID, but they're at much less risk of getting COVID. I think before Delta variant, what I was quoting was people who are fully vaccinated are 8 times less likely to be infected with COVID and 25 times less likely than an unvaccinated person to get severe COVID or die from COVID. But Delta has changed that math because it's so contagious. So now with the Delta variant, if you're vaccinated, you're about 3 times less likely than an unvaccinated person to get COVID, and about 10 to 15 times less likely to get severe COVID requiring hospitalization. So the vaccines are still very effective in preventing severe disease in most instances. We are going to see breakthrough cases, but the vast majority of COVID infections still are in unvaccinated people, and the overwhelming majority of severe COVID admitted to hospital are in unvaccinated persons, but sometimes in immune compromised people. In my opinion, what's happening is we are asking the immune system of fully vaccinated people to do too much for our communities. And we can reasonably predict that until we get enough of us vaccinated, this virus will continue to mutate as these RNA respiratory viruses do. It will continue to circle back through our community and continue to infect susceptible population for the next 12 to 18 months at these pandemic levels as we try to shove this virus into a more endemic, milder disease. Thanks.
Thank you, Dr. Jackson. That's remarkable that you had 2 hours of no COVID patients. But I think one thing that Dr. Johnson is really highlighting is that what we're seeing all around the state is people who are declining the vaccine, sometimes because they say it's experimental or it's not proven or whatever their reasons are, but they come to the hospital and they're sick and they want every treatment you can possibly have, including a lot that's experimental, that is incredibly labor intensive. It's incredibly exhausting for our staff and is leading to the denial of healthcare services to other people who need them because of the space that it takes up. So I think it's really important that people understand that. Dr. Sorensen, Dr. Johnson spoke about some pregnant women that they're seeing, and I think you've got real expertise in this area. We'd love to hear about that.
Yeah, thanks, Cassie. Yeah, I'm a maternal fetal medicine specialist, so I take care of sick pregnant women. And for the first time during the pandemic, we are seeing huge numbers of sick pregnant women, really sick women. I've been in touch with people, my colleagues around the state. We're seeing ICU admissions, we're seeing maternal deaths, we're seeing babies born prematurely, either to help the mother breathe or to rescue the baby because the mother's hypoxic. And it's really heartbreaking. As Mark was saying, we're also seeing a lot more people who are testing positive. When we started screening patients on admission or prior to admission for, say, a scheduled C-section or an induction of labor, we had a very low percentage that were asymptomatic that were positive. Now, with the vaccine, we have patients who are asymptomatic and positive. And unfortunately, the Delta is so infectious that people who are positive for COVID can spread it to other people. And because so relatively few pregnant women are vaccinated, they're much more susceptible. So it's all about, it's 100% right now about the vaccine. Pregnant women need to get vaccinated. We need you to be fully vaccinated. We need you to do it now. It's heartbreaking to spend my day in the ICU taking care of women who are pregnant and may not make it and maybe leave their babies motherless. It's really rough, and it's really rough on our staff. Again, as Mark was saying, we have staff who've been exposed and have to be out, so we're short-staffed all the time. Our staff is stepping up and doing a great job, but they're exhausted and sad. It's just very sad right now. Vaccine, as everyone knows, the Pfizer vaccine is now fully FDA approved. We have lots of experience in pregnancy. There are no reasons that pregnant women should not get vaccinated. The vaccine does not cause infertility. The vaccine cannot give you COVID. In fact, the vaccine may protect your infant. That we see there are COVID antibodies in breast milk, and in the maternal serum, which can pass to the fetus. So there are all kinds of reasons that this should be not even a question. We early on in the pandemic, before we had all this information, we were a little more cautious about decision-making around COVID. We always have what we call a shared decision-making model. So we explain to the patient what our thoughts are and what the evidence is, and then they decide what they want to do. We have so much more information now that I'm being very directive to patients. I'm telling them that I strongly recommend that they get vaccinated as soon as possible, and I just can't emphasize that enough. We do have treatments available, and the thing is that they do work. But I have to tell you, when you have a pregnant woman and you're throwing everything that you have at them, they're still at risk of dying and of long-term sequelae. So, and their babies are at risk of prematurity as well. So again, all I can say is please, please, please tell every pregnant woman you know, everyone around you, get the vaccine. It's incredibly important.
Thank you, Dr. Sorensen. These are some very heartbreaking stories we're hearing about babies starting their life without their mother, or with their mother very severely impacted by the disease and unable to care for the baby. So really hope that message will sink in with people. Dr. Carlson, let's hear from Multicare, what you're seeing as the view across the whole system that spans a big part of the state. I think you're muted, Dr. Carlson.
Thank you, Cassie. I always tell people that most people like me better muted, but in this case, I'll be better off muted, unmuted. So in multicare, we have similar challenges. So we all knew that there was going to be a fifth wave of COVID, but I don't think any of us imagined that it was going to be this fifth wave. And I've not ever in my career been concerned in the way that I am now about the challenges of our providers and our systems, and about the very real possibility that we're on the edge of not being able to properly care for people in our community. So multi-care, we have currently today, that number fluctuates actually minute to minute, but about 275 people across our system that have COVID. About 80 of those are in Spokane, and the remainder are here. We've had as many as 321. And like everyone else that you've heard, 96 to 98% of those individuals who are in our hospital are unvaccinated. So the hospital crisis was completely preventable. Had we had 100% vaccination within our communities, we would have 10 to 12 people in our hospital with COVID, as opposed to 275. It's staggering. And beyond that, it's heartbreaking. And that is the challenge of the Delta variant, which behaves a lot more like measles than the original COVID-19 infection. Like others, largely, this is a younger group of people. We do have all age spans, but we have many people that are younger. We have people that have died that are very young with families. We have children in our hospitals. Until sometime this year, we might have had one or two, and now we have children that are coming in sick. We have mothers and babies likewise that are ill. And the outcomes, if you look at the data for moms and babies, is really, really bad compared to those who've been vaccinated. Everywhere we're struggling with capacity. We have, there are days when we've had over 100 patients that were boarding in our emergency rooms waiting for beds. We have well over 100 patients that are waiting for a placement out of our hospitals to get into a skilled nursing facility or an adult day home. Our urgent care clinics, and we have many of them, are struggling with volume. And so a facility that was designed to deliver care within 30 minutes is taking hours. And by and large, nearly all of that care is for people seeking care for respiratory disease, seeking COVID treatments, et cetera. So it's really, really remarkable. The biggest challenge we have is staff, like everyone else. The care for these patients is incredibly difficult. When they get ill, we do something called proning, which means we lay people out on their stomach to help them ventilate. It is extremely labor intensive to do that. There are some beds that people have that help you with that, but nobody has enough of those beds to make it help. So the labor that we're using to take care of people is enormous. Our staff absolutely is struggling. We're asking volunteers to come in. We're mandating people to work different jobs. We have a large regional program. We call it Helping Hands, where our folks will volunteer and then they'll be assigned to go help in our units. And I think, the one thing that's quite remarkable is early on, I spent a great deal of my time speaking to our community leaders, mayors and legislatures to talk about what was happening. And they all wanted to do lots of stuff for our staff. And at that point, we had a lot of empty beds and a lot of staff that really wasn't working very hard. And now we have staff that are on the edge. So I really would encourage, our community leaders and everyone to pay attention to that. Please help them. Please, at the very least, show them your compassion, your sympathy, your support. And if there's other things that you can figure out to do for them, I really think that would be very, very helpful as well. I do want to get on to another topic, mass events. So this is fair season in Washington. There's a state fair that's going to happen not very far from Good Samaritan Hospital that has over 100 patients, right around 100 patients with COVID today. The hospital's full. And we are, over the course of the next 3 weeks, likely going to bring in an additional 1 million people to that community. And I am very, very concerned about the stress that will put on our emergency room and the stress it will put on our systems, because undoubtedly a number of those people are going to need care for routine stuff, cuts and bumps and broken arms and legs. But likely somebody's going to think that they have a heart attack or chest pain or a stroke or a seizure or something else. And God forbid there's a mass event. Our state does not have the capacity to manage. I'm saying our state doesn't have the capacity to manage a mass event at this point. And, you know, I would look no further than the news and what's happening in New Orleans right now in the Gulf Coast with the hurricane. They are extremely stressed. I have a good friend that I've communicated with that they're struggling with a mass event and a catastrophic event on top of a catastrophic event. So I guess my take-home point here is that people need to get vaccinated. This was the capacity issues within our hospitals, the strain on the healthcare system was 100% avoidable. And we've got to rally our people and rally our communities and figure out how to get people comfortable with the vaccine, or we're going to continue with this for some time and potentially have another variant that does the same thing. And eventually our healthcare system will not be able to respond.
Thank you, Dr. Carlson. I think one of the things you highlighted was people's desire to support healthcare workers and, you know, can I do something for them? How can I show them my appreciation? And one of the things that we're hearing from the folks who are caring directly for COVID patients every day, who are very highly vaccinated. If you work with a COVID patient, you got your shot. From those folks is the best thing you can do to support me is get vaccinated so I don't have to take care of you. I do not want to take care of more people with COVID. So keep yourself from getting to be my patient. Mike, we'd love to hear what's happening in rural communities around the state. You represent one, but you have lots of connections with your peers around the states.
Sure.
I know the crisis there is particularly deep.
Yep. My name is Mike Glenn. I'm the CEO at Jefferson Healthcare. We're a small critical access hospital located in Port Townsend, 25 beds and a series of primary care and specialty clinics. And while we may be a small hospital, we represent the healthcare delivery system for the entire region, which I think is similar to most of my rural colleagues. And I think the best way to summarize it is same situation here, but just smaller numbers. And maybe to give you a better sense of that, I can explain a little bit about what the weekend was like and what we expect this week. Lots of activity in the emergency department. All of the hospitals to the west and to the east are under similar strain. So it's a matter of continuous communication with them to see who has it maybe a little less bad. Over the weekend, we hit our high of inpatient COVID patients of 6, which interestingly represents 24% of our inpatient population as well. The current census is about 18, including one baby, which is manageable. But given the existing staffing crises, continues to place a challenge on us, particularly as we look toward this week, not knowing what to expect. We have suspended all inpatient elective procedures. We had 5 cases scheduled for today and tomorrow that we canceled on Friday. And I think it's important to note that, these elective cases may meet the definition of elective by, someone like me.
I lost Mike. Did you all lose Mike as well?
We'll work on getting him back. Yes, Cassie.
Okay, shoot.
Yeah, Cassie, this is Dave. I lost him too. I do maybe want to touch on that just for a second. You know, we at Multicare have canceled virtually every surgery that we can. If it's not urgent or emergent, it's canceled so we can divert staff and so we can fill up our post-anesthesia units with patients that are extremely ill.
And Dr. Carlson, can you give some examples of the kinds of things you're canceling? I think one of the things that people hear that and they think you mean facelifts. And I think it's really important for people to understand how serious these procedures are, especially for the people who are waiting for them.
Well, you know, I mean, at this point, it's an awful lot of things. So if you have a joint that needs to be replaced, that's canceled. If you've had, you know, a surgery, so maybe you had a colostomy, and you need to have it reversed, that's going to be canceled. Typically, you know, in most of the time here, we've only canceled things, you know, that, you know, there are a lot of things in the last several months that we could have continued to do, but now we're canceling everything that we can that's happening in our hospitals. Again, it's just so we can have staff and we can have places to put people. So unless you're likely to be, you know, harmed or, you know, in undue distress for a surgery, you know, within the next 30 to 60 days, we're canceling it. And we're doing that week to week. This is frankly the most severe restriction on cancellations and surgeries that we've had to put into place since this started.
Mike, I think we got you back online, so maybe you can continue. We lost you right when you were talking about what kinds of procedures you're canceling.
Got it. Yeah, sorry about that. So we expect that to continue for the foreseeable future, and you know, not only create inconvenience and additional pain for the patients that were expecting to be treated today, just push that treatment down the road and probably continue the you know, the surge of patient activity that our staff too is getting pretty tired of managing. As Dr. Sorensen noted, we're also beginning to see more patients where their COVID positive status is secondary and incidental to what brings them in. An acute condition, maybe why they seek care, like we had a case of acute appendicitis. And while we were working the patient up for surgery, it indicated that she was positive. So we're beginning to see this more and more now, and have just concluded that it's a thing related to just higher community prevalence rates of COVID. As my colleagues have spoken about, the biggest rate limiting factor continues to be staffing. I mean, I think that conventionally, when you would look at capacity for hospitals, you would look at you know, licensed beds or beds set up, and then pretty much think that that is what the overflow capacity would be. And prior to the last 9 to 12 months, that was safe because staff was available, and it was just a matter of filling those positions. Really, for the last 6 to 9 months, that has not been the case, and that every hospital is continuing to struggle. You know, not even week to week, day to day, putting staff together to safely care for our patients. And you know, I think the challenge of that is when we have twice daily staffing huddles to try to understand what our you know, what the level of patient activity, the discharges and admissions that we anticipate, who's in the emergency department that needs to come upstairs, and when we try to gauge the number of patients that we can safely admit, it's hard to look out much more beyond 36 to 48 hours because we are constantly pulling in staff members above and beyond what their FTE is to come in and do a shift tonight in order to provide safe care, and just worrying about the shifts 36, 48 hours to come when that turns into a crisis. So it's this constant source of kind of fight or flight here that I think is really starting to wear on on staff. And I'm sure I speak for my colleagues. They continue to be amazing and do whatever they need to do to take care of their communities. And lastly, I would like to follow up on Dr. Carlson's comments about really how the community can help their local healthcare system. I think first and foremost is continue to be vaccinated. The statistics that were cited about number of patients being treated unvaccinated is consistent with what we've been seeing, and consistent not only statewide but nationwide. That's probably first and foremost what you can do, but also recognize that we're still in the soup with this, and that there is far more community prevalence now than there ever was. So putting yourself in harm's way of going to big events or even inpatient dining or bars increases your chance of contacting COVID tenfold, and then will likely present to the already overwhelmed local healthcare system. I do want to cite a great example of a very difficult but community responsible decision that was made in our community. For all of you wooden boat enthusiasts out there, Port Townsend hosts the Wooden Boat Festival each year, and it's a wonderful event, and it's sort of the keynote event for the Maritime Center, and many local businesses depend on it. But it brings 20 to 30,000 people into our community over a weekend, and it was scheduled, I think, for the second weekend of September. And just last week, the director of the Maritime Center canceled the event, which was not an easy decision to make, but it was the right one, given what we are facing and what I think the entire state is facing. So I would just encourage that level of support. Probably is quite a bit more meaningful than maybe banging on a pot to recognize the good work of a nurse and a technician.
Thank you, Mike. I have a follow-up question of what you said when I aimed to Dr. Carlson. So for that patient, as you all both have noted, that people are coming in for another thing, like Mike noted, appendicitis, and then finding that person has COVID. Their recovery from the appendicitis is going to be compromised by having COVID, correct? Is that correct, Dr. Carlson?
Yes, there's no doubt about that. In fact, the rationale for universal testing of pre-op patients and patients who are coming into the hospital is largely based upon the idea that somebody having an elective process while they have COVID was likely going to create a worse outcome. And so no doubt that, any stress or any illness, let alone COVID, when you're ill with something else, is going to complicate your recovery and make it worse.
So if someone was having a joint replacement, you would delay it, but if someone having acute appendicitis, you can't delay it. They've got to have the surgery. And so now they've got the surgery and COVID, and it's going to be a lot harder for them to get back on their feet.
Correct.
Yeah, okay. Thank you. Well, I think we're open for questions, either via the chat or feel free to ask us verbally.
So Cassie, this is Dave. Maybe there's a couple points that I could make as we went through this. So, early on, we didn't have, we had a lot of challenges with getting what we called stuff, right? Supplies. We're not having, the reagent or the lab issues that Mark's having. However, we are very, very low on BiPAP machines. So, for those of you who don't know this, you want to keep COVID patients off of ventilators. They have better outcomes. So you start with high flow oxygen. When they can't tolerate that, you move to BiPAPs. And then if all else fails, you wind up on a ventilator. And we've been having to move these BiPAP machines around our health system just to keep up with the demand at any given location. And, so we tried to get some more. We tried to rent some. We can't get them. It's at least 6 weeks to buy more. And, then there were some ventilators that had been set aside in a warehouse that actually could have been converted to this. Unfortunately, in the warehouse, they didn't get plugged in, so the batteries failed. And so until there's new batteries in those machines, they're not able to be used, which is a real challenge. There was a health system in another state, but not too far from Washington, that had their oxygen tank supply. So the oxygen comes out of a big tank, comes through a valve, and then into some supply lines. Their tank froze. They had to replace equipment because they had too much demand on the oxygen. So we battened down our hatches. We did preventive maintenance and checks on all of our oxygen tanks, and we brought in additional portable tanks in the event that we create too much demand on our own system. So those are very real things. And then finally, I don't know what my colleagues are doing, but we've gone back to the most restrictive visitation policy that we've had since the pandemic started, which I will tell you as a primary care doctor and a geriatrician, that breaks my heart. It means that people are going to be super ill. Some people, without a loved one nearby. And that's not good for them. It's not good for the family. It's not good for the community, but we have no choice.
David, if I could echo that, we had a day last week where we were utilizing every single BiPAP or high flow nasal cannula device we had in our healthcare system. And largely that's because when we report our data saying this is the number of critically ill patients in our ICU, there's another large cohort of critically ill patients that we manage on our step down unit that for all intensive purposes are getting ICU level care. But we have them on BiPAP or non-invasive positive pressure ventilation, or they're on these high flow nasal cannulas supplying profound amounts of oxygen. And we were at a point where if we had one more patient, we wouldn't have services to offer them. And that's the delicate art that I know that we're all facing. So I'm glad you brought that point up. Thank you.
Thank you. We've got some questions about kids and pregnant women and so maybe Dr. Sorensen and Dr. Carlson, one of the hospitals within the multi-care system is Mary Bridge Children's Hospital. And so there's a number of questions, but they're how many pregnant women have died, how many deaths in infants, and how many premature births. I don't know if we know, I don't know those numbers, but maybe Dr. Sorensen does. Are other facilities besides Swedish also seeing more pregnant women with COVID? Is that a trend? And then another question about any sense about how children are faring during this new wave. So maybe if the two of you could take a stab at this variety of child and pregnancy related issues.
Yeah, I don't have a number for you about pregnant women who've died. I know there are a number of them. It's not just a Swedish thing. I was on a call at 7 this morning with Providence across the state and the West Coast, really, and we're seeing it everywhere. It seems that it comes along with the Delta variant for whatever reason. It's actually pretty, when our patients get really sick, it's pretty common to need to deliver them. And it's usually by an emergency C-section and sometimes even in the intensive care unit. And the reason for that is either the babies are getting distressed because their mothers are so ill, or that we need to deliver the baby to help improve the mother's breathing, because having a fetus pushing up on the diaphragm does not help with the breathing. Somebody mentioned proning. Proning is real hard to do in pregnant women. There actually is a guideline now for how to prone a patient who's pregnant, but it's really difficult. And then once you do that, it's also really difficult to monitor the fetus. So that's been a problem. In terms of kids, we do have a pediatric service at Swedish, and we definitely are seeing more COVID cases in kids. And of course, the young ones can't be vaccinated. But David might have a better answer to that, being, over Mary Bridge.
Yeah, so I can tell you, throughout the course of this until the Delta variant arrived, it was rare to have a patient in our pediatric hospital with COVID. I saw a couple, but it was rare, and never in our neonatal units. And so we don't have a lot yet. I want to be clear. We have 4 inpatients in our children's hospital that have COVID, but of course those are children. And we have 1 in our neonatal unit that has COVID. I'll also tell you that, this excludes because we have such a crunch on beds, we try to put as many patients in our children's hospital as possible because it offloads the rest of the system. So we'll take patients up to 30 years old in our children's hospital if they meet certain criteria. So that's just a matter of flexing. So, kids are getting sick and they're going to get sicker, and our numbers aren't massive right now, but I am very worried that could shift if you look at some of the experience at some of the children's hospitals in other states.
Thank you. All right, I think this may be a very easy question for all of us. We mentioned concerns about mass events. Do we think it's a bad idea for events like the Puyallup Fair to go on considering the current situation? Yes, we think it's a bad idea. Anybody disagree with me?
I think it's a very bad idea.
Yep. And we, as Mike said, people should be incredibly cautious about going to any kind of mass gathering right now. I think that none of us are going anywhere that qualifies as that. And anywhere we go, we're wearing a mask. Always, always, always.
And Cassie, I would point to, we have some data about things that are likely to happen. So if you look at if you think back to the holidays, right around Thanksgiving, we started to see this big surge in infections. And then as we approached Christmas, it actually started to drop off until after Christmas. And then we saw the trend of backing off, turn around, and a relatively rapid acceleration for a bit of time until we hit a higher peak and then dropped off from there. Any of these mass events are going to do that on some scale. And I think, we are all concerned. We know that our kids need to get back to school. We need to be really rigorous about the processes at our schools and making sure that our kids are well informed and that we understand what our schools are doing to prevent spread of infection, because these things have a lag of a couple of weeks before they impact us. So my worry is that maybe in the course of the next couple of weeks, we'll start to see a trend downward, only to see that reverse and go back up when there's more and more activity. And it's super concerning with the level of infectivity of the Delta variant and what it means for the populations.
Thank you. A question about how bad hospital staffing is right now, and I think everyone would say this is our most significant stress. There's a kind of related question about the number of beds, and that Washington does have fewer hospital beds than other parts of the country, which is correct, but it's staff that's our problem. There is space and there's space in hospitals, and we could make more space in conference rooms and hallways and such, but you need to have staff to care for patients. A piece of it, maybe Dr. Carlson, I'll call on you for this as well. A piece of the staffing crunch is that people are caring for people who are still in the hospital who don't need hospital care any longer. So Dr. Carlson, I know this is something you're particularly passionate about.
Yeah, so we've seen that phenomenon, ever since this started, and to some extent understandable because of the challenges. But nursing home capacities are down, and we're having a great deal of difficulties getting those patients out. We go to the extent we try to lease beds so that we can discharge our patients. We worked with our governor around regulations and creating some mandates for the post-acute facilities to take patients. And, so that the challenge that we have is, as a hospital, you cannot say no. You can't not take a patient when they come to your emergency room and they need care. And you can't discharge them until there's a place that they can go. So we are, in both on the front end and the back end, we're the solution of last resort. And it's failing us right now. It's really, really, really a challenge. And so it just simply exacerbates the staffing challenges that we have. So we are bringing in, we have in various parts of our organization, we have our outpatient staff, particularly nurse practitioners that are coming in to help staff nursing units. We have, if you can imagine, we have surgeons that are helping out our hospitalists because we've canceled surgeries. Our surgical staff is being deployed wherever we can to help out our med-surg and our critical care staff. And we have, as I said earlier, we have several hundred volunteers that are being assigned around the system to help in whatever they can. And some of those volunteers are very skilled. Some of those volunteers don't know anything about hands-on patient care, but they can help run specimens. They can do a lot of stuff. They can make a meal if we train them properly. They can deliver meal trays. So we're using all of those people across our system right now because the strain is so bad. And it's a staffing issue more than it is a physical capacity issue. We have tents that have gone up at 2 of our hospitals, at Good Sam and Tacoma General, and kind of in a window of treatment that are having to be in those rooms, and we need to keep them safe.
Yeah, I'd like to follow up on that because it's a huge, I think, underappreciated challenge related to staffing, and that is difficult or almost impossible to discharge patients. Because usually when a hospital admits a patient or a hospital has a patient, the thought is, well, there's probably some clinical reason for them to be there. In our case, sometimes the moment they are dropped off, it's very clear that there isn't a clinical reason to be receiving acute care, but the hospital emergency department is a more suitable place than where they came from. So then begins a incredibly labor-intensive, mind-numbing exercise of trying to weave through the administrative hurdles to identify a facility that might be able to take care of the patient and arrange for transfer. And all of those facilities are dealing with the same staffing shortages that we are. So it makes that situation even more difficult. I will say that through Cassie's team at WSHA and the Healthcare Authority and the Department of Social and Health Services, that they have been incredibly responsive, trying to remove barriers in that process and help us work through that. But if you lean into the process and stay focused, you can get there, but it takes months from the time the patient arrives to the time you get over all of the hurdles and then identify an appropriate placement and execute on that. And all the while, many of these patients suffer memory impairment issues or other behavioral issues that result in one-to-one treatment. Or a one-to-one sitter to make sure that they don't harm themselves. And so not only does it exacerbate our staffing crisis, it exponentially exacerbates the staffing crisis because that one patient can't take care of the 4 or 5 patients that they might take care of. So at Jefferson, we've had as many as 4 patients that did not require acute care that we were taking care of only because we could not find or couldn't find a adult family home or a memory impairment facility or a assisted living center or a skilled nursing facility that would accept the discharge. And it's not like these organizations are being difficult or challenging. They're just struggling with the same issues we are. But the implications to an already stressed acute care system are staggering.
Thank you. Dr. Johnson, do you have an estimate of what level of vaccination would need to be reached by the community to put a stop to Delta, or at least put a stop to this extreme strain that we're experiencing now?
Because of how much more infectious Delta is, people might have heard of R naught, that the basic reproductive number for Delta is much higher than the previous strains, either the Alpha variant or the D614G from last year. So while people might have heard before, well, we need about 67% or so of us fully vaccinated of the entire population, not of eligible people. Now that math has changed a lot. And so we're now talking about 85 to 90% of people have to be fully vaccinated based on how transmissible the Delta variant is right now. We have to remember that this is a much more infectious strain of the virus. And that is because largely it produces viral titers or amounts of virus in the human respiratory tract that's about 1,032 times higher than the Alpha strain, which was much more contagious than the previous strains before that. So Delta has changed the game. And we're starting to see evolving data saying, again, people who have been infected with COVID and had severe illness, if they have severe illness and had COVID, they probably mount some degree of protective immunity. And the likelihood that they would be reinfected over the intervening 3 or 4 months is very low. We have to acknowledge that. But because these variants keep emerging, our immune system isn't adept enough to then provide immunity for the next strain 6 months from now. So we know that the vaccines in general provide a much more robust, durable, and predictable immune response than naturally acquired infection, and also reducing the risk of having to go through severe COVID illness. So as we think about this, and as we get ready to potentially starting to have vaccines authorized for younger children under the age of 12, hopefully in the near future, and as we now have a fully FDA-approved product with the Pfizer vaccine for certain age groups, these are incredibly powerful tools. But unfortunately, the math keeps changing, and that's because this virus does what RNA respiratory viruses do. It mutates. It just wants to infect us, and it will keep looking for survival advantage for the virus. So we're going to keep seeing this pop up again and again and again until we get enough of us vaccinated. I know. Sorry. One more quick point. There was a recent publication in MMWR that comes out of the CDC data, and so they had a case cohort study, and they found that people that were infected with COVID during the calendar year of 2020, who since have been vaccinated, were 2.2 times less likely to be infected with COVID again than people who are unvaccinated. In other words, even if you've had COVID before, if it was a while ago, there is still a benefit to getting vaccinated to reduce your risk. Thanks, Tanya. Sorry to cut you off.
Oh, no, not at all. I just wanted to point out to just extend your thoughts there. Pregnant women are much less likely to be vaccinated than other people. And I think the last number I heard is something around 40%. 40% is not 90%. So we're a long way away from where we need to be.
Thank you. And just want to remind everyone that every vaccinated person is very likely to avoid hospitalization as well, which will really help the current hospital capacity crisis. I'm sorry, we're not going to get to all your questions, I don't think, but I do want to take one last one, which is that Washington had, the question is, I understand that Washington has a unique system for sharing resources when ventilators and other equipment get scarce. Can you explain this? Yes, we are the first state, I don't think we're still the only state, but we were the first state to have an agreement, a written agreement among all of our hospitals in the state, facilitated through the Hospital Association, that no hospital would reach crisis standards of care, which is when you're really rationing care in a live or die kind of way alone, and that we would instead share knowledge, supplies, medications, expertise, equipment, all around our hospital, patients also all around the hospital system. And so that continues to function. You have seen other state reports of other states saying, hospitals the ICUs are full, they're turning away patients, like you can't find any place to get care. That's not happening here, or so far it's not happening here. So we are really glad to see that and continue to appreciate the cooperation of our hospital leaders. Can folks stay on for 5 more minutes, or do you need to go, our panelists?
I'm okay.
Okay, all right, let me just ask a few more questions. There's a couple of folks asking the question about, do we think that reopening schools is the right move to do now? I'm sending my kids to school.
So this is Dave. That's a really tough question, right? This is sort of a benefit, I think that, or a cost benefit thing. The challenges of having children out of school are great, and there's an enormous impact on that. So I get it. I think this is a place where really having I think there ought to be really strong consideration for vaccine mandates for any child that's eligible. So that's 12 and over. We have mandates for about every other vaccine, but not this one. I think that it's time. That would go a long way. And then really, really good mitigation efforts for others. So increased ventilation, masks on anybody who can use them, keeping distance. And then, finally, real preparation for the outbreaks that are absolutely going to come, and how to deal with them, and how to move from a normal traditional process to a hybrid process so we can keep people safe and also keep our kids socialized at school. So I have a child that's a senior in high school, and I'm worried about it, but she is going to start school in a couple days.
I want to echo Dr. Carlson's statement about the vaccine for school kids who are eligible. I know quite a few private schools are requiring it. Public schools, not so far. We require the vaccine for polio to go to school. The chances of getting polio, we still should. I don't mean you shouldn't require the vaccine for polio. The chance of getting polio in a school setting seem very, very tiny compared to the chance of getting COVID.
Cassie, if I could just add to that, on Saturday, we had our Infectious Disease Society of America call with the CDC, and we had the president of the American Academy of Pediatrics on. And there was a great, robust discussion about this. And I think one of the points they made is they said, the CDC's most recent school guidance is trying to take a balanced approach to this. If the only goal here was to prevent COVID, then we'd say, shut down the schools, kids stay home. But there's so much more to it. And so we know that there's a significant harm of having kids out of school for all the things that have been discussed already. And so that's why the CDC is taking the approach that they are. But I think we have to get back to saying, well, the schools that have robust mitigation plans in place, they're the ones that are going to be successful. They're not going to be perfect, but they're going to be the ones with the best success. We know that schools had really robust mitigation strategies, were able to keep transmission rates reasonably low. So we have to get these basics right. And we know that as a part of a belt and suspenders approach, vaccine and mask go hand in hand. And so until we can get our younger children vaccinated, the message should be, we need every adult vaccinated against COVID to protect our children who can't at this point protect themselves. But we also need to remind ourselves that masking is a safe, effective, and straightforward strategy. And so we shouldn't be debating this at all. This detracts from our ability to have good mitigation plans in place from school. Thanks.
And I would like to say that we just totally appreciate Governor Inslee for making masks mandatory in schools and for requiring vaccinations for teachers. Those that other states have the total opposite approach is just mind blowing. So very huge kudos to him for doing the right thing on those topics for sure. How about people using ivermectin? Dr. Johnson, are you seeing that? Your community I suspect might be the more likely to see ivermectin.
Yeah, we hear about this. And I would just say that we do not have clinical data to support its use. And so that's why the National Institutes of Health Consensus Guidelines and the Infectious Disease Society of America COVID-19 treatment guidelines recommend against the use of ivermectin for either COVID prevention, management of mild outpatient COVID, or management of severe COVID. And so where did this come from? Well, we had to, in the beginning of the pandemic, very quickly try to understand what might be used as therapeutics or treatment for this viral infection. And I think, as Tanya already alluded to before, our ability to treat viruses are imperfect. The best treatment of a virus is prevention. Don't get the infection. And that's where vaccines come in. So when they were looking at possible drugs to repurpose that are available, we use ivermectin to treat particular human parasites that can infect humans called strongyloides, which is found primarily in tropical regions around the equator, and then African river blindness or onchocerciasis. And so outside of those things, we don't, or potentially sometimes off-label use of certain things like scabies, we don't recommend use ivermectin for infectious diseases beyond those. In other words, ivermectin in the lab in a test tube, very, very weak antiviral activity. Much, much, much less effective in the test tube than, for instance, remdesivir, which we use in the management of COVID, and its benefit is still modest. So when they went on to clinical studies, so far we have not found any convincing evidence that ivermectin works. So Merck, the company, the for-profit company that makes ivermectin, has put out a statement saying, do not use our product to treat or prevent COVID. We do not have data that says it works. And we've heard the FDA say, do not use ivermectin. And the reason is because people can get hurt by this. In the test tube, when ivermectin showed some antiviral property, it was at concentrations thousands of times above what I call the therapeutic threshold, meaning the area where you start to lose benefit and you start to hurt people. And so people are using veterinary products of ivermectin. People are using human ivermectin off-label, and we just don't have the data to support it. And now there are studies that are ongoing, but we have to just keep doing the science, and that informs how we do things. As physicians, we practice evidence-based medicine. This is a pandemic. This is a critical time, but scientists are working as fast as they can to get us the answers that we need. And right now, the answer based on the data is don't use ivermectin. Thanks.
Thank you. Okay, I'm going to ask one last question, which is the kind of crystal ball question. Do you all have any projections about how long this surge is going to last?
So this is Dave. I have to say that, my prediction about this surge was that it was going to come, but it was going to be muted because of where we were, and I was wrong. So I've stopped predicting. Our predictions here, we're going to have hospitalizations go on for at least another week or so at the levels that we are now. But the rate of infection in the community is it's amazing. And it's, as Dr. Johnson has said, this is more like the measles than it is the original, COVID virus. And so one person can affect a lot of people and so on and so forth. So the exponential ability to create infection and the higher numbers that we're seeing is pretty remarkable. So I don't have a prediction.
I would say one thing to consider, and this has happened in other places where Delta came before it came to us, a variant that is this virulent goes through the community quite very quickly, and you do tend to have a more rapid burnout of the virus than you do with less infectious variants. So there's maybe some hope there, but then there's the Lambda variant and many more to come. So that's the other part.
If we were to use what we've learned from UK's Delta surge a few months ago, they had a meteoric rise, a more rapid rise in cases than we've ever seen before. We saw the same thing here in the US in our Delta surge, but they had a huge rise, massive number of cases, and then a quick drop off. And it was over an 8-week period. And so it would be reasonable to think that maybe we see the same thing with ours, but I would also say that the UK vaccine rates were higher than ours nationwide. And so just like David was saying, it's hard to predict it, but the UK data I think is telling. I think we're still seeing patients admitted to hospital with COVID who are dying. We're still seeing patients with profound morbidity after the fact. I think people are forgetting that point. In our hospital throughout the pandemic, our COVID mortality rate amongst patients with severe COVID admitted to hospital is 11%. And it's 11% only because the exceptional care that our nurses and pulmonologists and hospitalists, respiratory therapists, et cetera, are doing. And I know that's happening in all our healthcare settings. But when these patients leave the hospital, if they survive it, they don't walk out the door and everything's fine. There's a percentage that have lingering symptoms of malaise and fatigue for a few weeks. But there's also a big subset of people who are on oxygen for a period of 2 to 3 months. Even patients in their young 30s that are still on oxygen. But then we have another group of people who survive severe COVID who are going to be on oxygen probably for the rest of their life with severe post-COVID pulmonary fibrosis. So as we talk about these mortality rates, they're concerning for sure, but then the downstream impact on our health system is profound. And so as we get ready for when the Lambda variant comes and we get ready for the next ones, we're going to see another huge winter surge. And we're going to see another big surge next April. We're going to see another big surge in next summer. These surges, though, should keep going down and down and down in their magnitude once we keep getting more people vaccinated. Thanks.
I think a big answer to this question is that this is a very human-driven disease, and so the more people wear their masks, stay home, don't go to the peel-out fair, and get vaccinated. Those are things that will help mute the surge for sure. So really continue to call on our public to do those things for their own protection, their family's protection, their children's protection, and the community protection. I think with that, really appreciate you all coming, and we will be back with you, and hope that you'll continue to really beat the drum that people should be vaccinated and do everything they can to protect themselves. Thanks so much. Take care.